Hi, everyone that's tuning in tonight for our healthcare town hall. We're really excited to have you here. It's a very pertinent and relevant issue. The purpose of this conversation is to get an update on what we're seeing in healthcare, especially with the privatization of some aspects of healthcare, and also talk about what we can do and what you can do to protect yourself from being billed for medically necessary care and how we can safeguard our public healthcare system. I'd like to start with a land acknowledgement. We acknowledge that we are on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And this area is now home to many diverse First Nations, Inuit, and Métis people. I personally guide the work that I do based on the recommendations in the Truth and Reconciliation Commission and its recommendations to reshape our institutions from our schools to our healthcare system to our provincial government. Welcome to our healthcare town hall. As we all know, Canada's healthcare system is fundamental to who we are. We fought long and hard for national healthcare, starting with Tommy Douglas in Saskatchewan and then moved to a national plan. And we've also seen recent positive improvements to expand dental care on the federal level, which is very exciting. What worries me and why we're hosting this conversation is that we are beginning to see that the progress we've made to expand and strengthen public healthcare is being undermined. We are seeing the public healthcare really struggling to meet the need, which is why many of us are having difficulty getting access to a family doctor or a nurse for primary care, or waiting too long for surgeries or tests or in the emergency room. And we're also seeing the rise of for-profit care, and that's going to be the topic of the conversation tonight. I think you can join me in being understandably very worried about how these twin issues of public healthcare underfunding and the rise of for-profit care is going to affect the ability of our healthcare system to provide for us, impact the length of time it takes us to get care, the choices of healthcare treatment that are available to us, as well as patient outcomes. What this is going to look like in terms of an agenda is we have a series of questions that we're going to be asking our panelists. I'll be introducing them in turn. And then we will also be taking questions from you. We're going to start with questions that came in when people RSVP'd. We have a list of them. And then if you have additional questions, I really encourage you to put them in the chat so that we can collect them and put them in the queue. In addition, if you have, I really like to have commentary during a town hall like this. So if you have questions and comments that you'd like to put in the chat to communicate with the presenters or other audience members, I encourage you to use that chat function. So let's get straight into it. We're going to start with our panelists. Our first panelist is Robin Lennox. Robin is the member for Provincial Parliament for Hamilton Centre. She's our health critic for primary care and mental health and a practicing family doctor. Welcome, Robin. And Robin, my question was to start us off is, can you tell us a little bit about how you're seeing healthcare being privatized in Ontario and Canada? And what changes have happened that have allowed these changes to take place?
Thanks, Jessica. And yeah, it's such an important issue to me, especially working, in the public healthcare system. I wouldn't want to work in any other type of health system. And we hear from colleagues all the time who work in places where healthcare is more privatized, and the impact on patient access, on the experience of healthcare providers, on equity and access to healthcare is really profound. So I'm very proud that our NDP caucus is strongly supportive of a public healthcare system, and I think we have to do now more than ever to protect it because it's definitely under threat. And in terms of how it's been privatized, so when we talk about healthcare privatization, I find it a very interesting conversation to have with people across the province right now, because for the most part, privatization has been a bit hidden. There are types of privatization that we think about more commonly, and that's often based on the experience in the United States, where when we think about privatization, we think about needing to bring a credit card, needing to bring your money to the emergency department, being handed a $20,000 bill after, a procedure. And that's really what people envision as privatization. And certainly that is privatization in its extreme. But there are a lot of ways that our Canadian healthcare system has been infiltrated by privatization that are a bit more insidious. And I think for that reason, a lot of people don't realize how much of our healthcare system, particularly in Ontario, has been moved towards privatization over the last several years. And so, what does this look like? So, when we think about privatization, I often categorize it into patient-facing privatization and more hidden privatization. And patient-facing privatization has definitely taken shape more over the last several years with the use of different legislation and also different models of care arising. One of which I think would be a very clear example to people would be this idea of concierge family medicine. And so concierge family medicine would be, primary care providers, physicians or nurse practitioners who provide, an enhanced service to people who are able to pay an annual fee for services that are beyond, medically necessary care. So under the Canadian Health Act, you're not supposed to charge additional fees for anything that is considered medically necessary care. But there are sort of a gray area around things that are outside of medically necessary care that you can charge additional fees for. And so we've seen a lot of private clinics arise that are trying to advertise, expedited access to a family doctor or a primary care practitioner. We've seen corporations use it as a way of attracting their personnel in terms of offering membership in these concierge primary care programs where people can mostly receive, diagnostic testing or physicals or wellness checks or things, but those are all coming at an additional cost. That's sort of some of examples of the patient-facing privatization where there's a very clear associated cost that's being put on the patient or on the corporation that's paying for this in order to access that care. That is relatively less common than what I like to think about as the hidden privatization. And so hidden privatization in our system is a little bit different because on the patient side of it, you're still just bringing your OHIP card and you're not getting a bill necessarily at the end of it. But what's happening on the back end is that we are publicly funding, but privately delivering healthcare. So public healthcare dollars are being used, your OHIP card is being used, but it's a private company that's delivering those health services, and they're charging an additional premium to the province. And over the last several years, there was legislation passed that allowed this government, the Ford government, to pay for those fees that are essentially higher fees to a private company than if those fees were delivered in a public hospital. And so when we think about, just in the past year, some of the announcements that have come from the Ford government that would be aligned with this, the two would be the recent announcement for the expansion of private outpatient diagnostic imaging clinics. So those would be private outpatient clinics where you can go to get your MRI or your CAT scan or your endoscopy, and you're going to get that diagnostic testing done at this private clinic that's outside of a hospital. You are still only bringing your OHIP card, but that private clinic is going to bill our public healthcare system a premium, a facility fee for having done that test outside of a hospital or outside of the public system. So it's a way that the government has marketed to us that they're going to try to cut down on wait times. But unfortunately, what happens is we may see in some circumstances people able to access those tests more quickly, but it's going to cost our system overall more, and it's also going to divert staffing. So techs who have to run those diagnostic imaging, doctors who have to read them, nurses who have to help administer anesthesia for endoscopies, they're going to be moved from the public system into these private clinics. And that's going to drain our healthcare resources in the public system and overall make things work less efficiently. But beyond that, it's also just costing our system more because for the same amount that we could pay for that MRI to be done in a public hospital, we're paying more for it to be done in this private clinic. And our healthcare resources, as we know, are finite. They're not, we don't have an ever escalating healthcare budget. And so the more we're paying for something, the less we're going to have to work with to deliver other programming in the system. The other major announcement that we saw alongside those lines was $155 million for expansion of surgical procedures in the community, particularly orthopedic procedures. And so again, those are procedures that are typically done in public hospitals, but because of the huge backlog in wait times, rather than invest in our public hospitals to be able to run their ORs more frequently, to be able to staff for longer hours, our government is putting that money into private outpatient surgical clinics, where again, we're going to be charged a premium to do the same hip or knee surgery that could be done in a public hospital, but is going to be done in a private clinic. And again, it's going to cost us more. Some people in some circumstances might notice differences in wait time, but overall, the efficiency of our system over time is going to go down and our healthcare resources are going to be drained. And the thing about this is that hidden privatization, I find, is the most dangerous because most Ontarians don't know that they're participating in it. They don't know that this is the direction our system is going. They don't know that it's infiltrated the way we deliver home care, surgeries, diagnostic imaging, even vaccination in some circumstances. And so we're seeing a lot of this money being scooped up by private companies, and then we're seeing our public health system flounder. And they're floundering largely because of underfunding. And if we funded our public system as it needed to be funded, it could bear the capacity to be able to do all these procedures in the public system. So essentially, we're creating the cure. What's the treatment is worse than the problem in this situation, where the government's looking at the problem, seeing long wait lists, seeing difficulty with people accessing it, and rather than doubling down on our public healthcare system and trying to address the problem at the source, they're outsourcing to private companies to try to fix the problem for us. That's charging us more money and further exacerbating the scarcity in the public healthcare system. So it's becoming a catch-22. And the biggest thing that we can do is make sure that our government is aware that we don't want to participate in privatization, whether it's hidden or if it's patient facing, it still undermines the public healthcare that we all believe in and that serves us well. And we know that even though it's sold to us as increasing efficiency, it actually is making things worse across the board and creating greater inequities in the system. And I'll end with just one example. So cataract surgery a few years ago was being touted as something that there were huge backlogs for. This was sort of early in the COVID-19 pandemic. And to try to address these backlogs, the government decided that rather than investing in our public health system to try to have these cataract surgeries done more efficiently and effectively, they invested in private for-profit centers to do cataract surgeries. And there was a large study done of almost 1 million cataract surgeries completed in Ontario after this funding change happened. And they wanted to see who this was benefiting, what the impact on wait times was, and what the impact on overall completion of cataract surgery looked like. And what we saw was basically the thing that we always fear about privatization is that it's going to benefit some, it's going to disadvantage others, and it's overall going to weaken our system. And that's how it bore out. So when they look at the 1 million cataract surgeries done during that study period in the years after the government changed this policy in 2020, they found that the rate of cataract surgeries went up by 22% only for folks in the highest socioeconomic quintile. For everybody else, the rates fell, and in the lowest socioeconomic quintile, the rates fell by 8.5% for cataract surgery completion. And overall, when they looked at the entire study period and how many surgeries took place, 900,000 fewer surgeries took place than would normally be expected within that period. So the efficiency actually decreased. We saw less surgeries being done. The only group that saw more surgeries being done was those who were more wealthy. And so this is exactly what we want to avoid. We want to avoid this separation into a two-tier system, which we know will benefit very few and will harm very many. So I'll leave it there for now and I'll welcome the other speakers. Thank you.
Thank you so much for that summary about the public facing and privatization of healthcare more behind the scenes, as well as that excellent example of what it's actually looking like in terms of health outcomes. Dr. Melanie Bouchard is chair of Canadian Doctors for Medicare and a pediatric emergency doctor. Dr. Bouchard, thank you so much for joining us. My question that I have for you is around how doctors are facing challenges because of the attempts to privatize our public system. We'd love to know, what are the challenges that doctors are facing, and how is this impacting the care that doctors can provide for patients?
Oh, it's rough out there, you guys. And I know as patients, you're feeling it too. It's not just on the healthcare provider's side. I think a lot of where we're feeling this squeeze is our difficulty with health human resource staffing. I know I work in a pediatric emergency department. I'm so nervous looking ahead to the fall and winter because I see blank spaces where there's shifts that I've never seen before since I started working there back in 2018. And for sure, this is multifactorial. This is not an Ottawa problem. It's not a problem of my institution. It's a problem in pretty much any healthcare team. I think we've all heard it in speaking with our friends, families, probably even ourselves. It's so hard to find family physicians. Wait times for consultants are really long. Surgical wait times are long. The ED, forget about it. It's chaos. And a lot of this does come down to our staffing difficulty. Of course, privatization, I think, is part of it. It is multifactorial. But what I see is some of my colleagues leaving to go work in the private system. And in Ottawa, we did have an issue when one of these independent health facilities came up. So the hidden privatization that Dr. Lennox was describing, we actually had difficulty staffing our publicly funded ORs because they were able to draw some of the OR nurses away from the public system by having more competitive pay or more reliable hours, more of a Monday to Friday setting, and frankly, less complicated patients and cases. And we have to remember healthcare providers, especially in the wake of that pandemic, are still feeling the effects. The burnout is high, and the prospect of being able to potentially have an easier schedule that better fits with your family life is really attractive. Unfortunately, it means that for those who rely upon the public system for their more complex surgeries or emergencies where things need to be available 24/7, it's getting harder and harder to find people. So we're really seeing a brain drain away from our public system. This is also true for the more blatant forms of privatization. I think many of us have probably noticed that there are certain platforms where you can pay to see a doctor or nurse practitioner online. Even though in person you'd be able to have it covered by your healthcare, certain platforms are actually charging people for virtual care. And I have had a colleague who used to practice longitudinal family medicine who now virtually does corporate virtual care just because it fit better for their lifestyle. So this is really sad to see. Again, I don't want the only solution to be, oh, well, these physicians should stay where they are. We should really fund and resource our public system appropriately. So it's a place where people want to work. So it's a place where patients feel safe to get care and get care in a timely manner. If we fund and resource our public system appropriately, the business case and need for these private facilities really does decrease. So I think that's a key part of the solution. As Dr. Lennox touched upon, we're also seeing concerns with the profit motive in healthcare. So I'm very fortunate. I'm working in a salaried model. I get paid the same, kind of regardless of what I see or what I do for my patient. If a child comes in with a big laceration on their face, whether or not I fix it with glue or fix it with stitches, I don't make any difference in pay. So I really just get to focus on what's best for the patient. If you are working in that for-profit model, especially if it's investor owned and you have to be accountable to investors and you're trying to generate a profit to pay off shareholders, that can get to be a really difficult decision. And those are circumstances where we'll see physicians potentially upselling patients. We recognize that there's a lot of information in the industry. I barely remember my ophthalmology lectures from medical school, let alone somebody who's never sat in a medical school lecture hall. So if a physician were to tell me, hey, if you pay an extra $2,000, this lens will be better for you, it's hard for patients to be able to make those decisions themselves. And I've heard several reports of this happening in some of my colleagues, and I think that there's been some great journalism on this as well. So it's really concerning. So us at Canadian Doctors for Medicare, we're doing our best to remind everyone that privatization is not a solution. Truly, like Dr. Lennox was saying, it creates more problems than it solves. It seems to be the knee-jerk reaction, but really and truly, it doesn't shorten this. It just rearranges them because you're taking those same doctors and nurses who are working in the public system and moving there somewhere else. So it doesn't necessarily solve one of our biggest problems, which is the fact that we have so few health human resources here in Canada. So we try to do a lot of education there. We're very fortunate to meet with staff in the Federal Minister of Health Office. We're happy to meet with parliamentarians and policymakers, anyone who will really speak with us. We meet regularly with Health Canada as well too to try and bring up examples of privatization. And we're also trying to work really hard to close this gap for virtual care because we really see that as a developing two-tiered bastion in healthcare right now. So I'm excited to continue this work and hear from you and take your questions.
Thank you so much for that summary from your perspective as a pediatric emergency room doctor and how it's affecting the quality of care that you and your colleagues can provide. I'd like to just do some administrative updates. I'm seeing some people posting questions and we're doing our best to answer them. Really appreciate it. Keep them up. It seems like we have a small issue with the chat function, so there can't be this the kind of free-ranging chat that we typically do, but we are working hard to bring it up again. It seems like it was disabled, so we apologize for that. Kristyn Wong-Tam is the MPP for Toronto Centre, the critic for the Attorney General and 2S LGBTQI+ issues. Kristyn, you're in the belly of the beast in Queen's Park, and it would be great to get an update from you on what Premier Ford and the Conservative government are trying to do with privatising our public healthcare system, and what can we do to protect ourselves and other patients?
Jessica, thank you, and thank you everyone who has spoken so far and everyone who's actually joined us this evening. As the two doctors spoke previously, what comes to mind here is this concurrent theme around a crisis in the making, and the crisis is now before us. I want to take us back a bit. It took us 100 years to build a public hospital system, 100 years to build public Medicare, and so the conditions that we see today with respect to staff shortages, overburdened ERs, and long surgical wait lists, and a shortage of family doctors and a shortage of nurses. When a crisis is before us, what do we do? Some would respond that we need to go private. And so that's kind of the ground that we're now sitting in. And so to Jessica's point about, what is happening, I can give you folks a few examples just in my own community. I have a constituent, an elderly constituent who needed medically necessary, cataracts. And she walked into the Herzig Eye Institute. You see their videos and commercials everywhere. And she was offered a diagnosis, and she ended up paying almost $8,000 for what would be simple procedures that you can get for free in a hospital. And so this is just one really, really horrifying example. And she's on a fixed income like so many people. It was an budgeted cost, and 2 years later she's still trying to get that money back, and this has set her and her family back significantly, not to mention just the undue hardship. And I think that in Robin's example through the study, this is just a commonplace that's just happening right across Ontario. This actually happened to my mother as well, where she went in for cataract surgery, and she came out $2,000 poorer, and we didn't have a conversation about it until months later, and then she realized that she didn't have to pay, but somewhere along the way she wasn't well informed, and there was never disclosure from the providers that these are services that are basically covered by your health card. So what can we do about this, and how do you protect yourself? Obviously there are many tools that are already out there. And some of those tools are on the Coalition Healthcare, Ontario Coalition Healthcare website. Some of it you can contact the Ontario Ministry. There is a particular hotline that one could contact. But before you do all that, I want you to just think about when you're walking into a facility that you need access to, and there is the requirement for what would be deemed as medically necessary. Start to document some of this interaction. Did they tell you what is necessary? Did they tell you what is covered in under OHIP? Try to ask some of these questions. Sometimes we sit in the clinic of our health provider and they are almost treated like gods. We don't question. They tell us what's going on and we sort of accept it as fact and we don't have any other option. So what we need to do is assume that, you are a consumer. You get to ask these questions even of your healthcare professional, and you have to be able to go through this, I think now, especially since what I would describe as minefields out there. And you may be walking into a situation where it's unassuming, but before you know it, it's rapidly, you moved along rapidly and the procedure is booked, and before you know it, you've paid out of pocket. So there are some places where you can find some recourse. I don't think it's necessarily fast based on what I have seen, but the information that I will have my staff post into the chat includes a little page that we've created on our website. And it's a resource that will help you if you need it, but you should always just have it. You can also contact, I don't have this 1-800 number memorized, but you can also email protectpublichealthcare@ontario.ca. Make sure you have all the pertinent information with you. So the dates, the invoices, whether or not they informed you that the service is covered by OHIP, and then it's almost just recorded as a transaction, what was said and who said it and what. You can also contact this 1-800 toll-free number. It's 1-888-662-6613. We'll post that in the chat as well. And anyone can make a complaint or ask questions by just calling, so you don't have to be there to file a complaint. You can also reach out to the patient ombudsman when it comes to issues involving public hospitals or long-term care homes. If you're sort of tuning into the seminar from the City of Toronto, you can also contact 311 Toronto. Chances are you don't contact the Toronto police, they're not going to do any of that investigation, but the early resources I provided are the most, I think, tactical and appropriate ones for you. One other thing I would want to point out is that, the Ontario NDP, obviously I'm part of the official opposition, but there has been work that's been done. And part of the work that we've been doing is actually putting forward legislation at Queen's Park that actually tries to counter what is happening out there in the real life. And so there have been 3 bills that have been tabled by the official opposition. Each and every single one of those bills trying to get to the heart of the issues with respect to inadequate funding in the healthcare system. So Ontario has the lowest per capita ratio funding out of any other province in the country. We want to correct that. We put forward legislation that actually tackled the adequate number of staff to patient ratio. You all heard about the staffing shortage, and as sometimes surgeries are canceled after the patient is prepped and ready to go. You've been on a diet all night. You've reduced your food intake, and you get to the hospital and your surgery is canceled. That happened to my spouse, who was going in to have her ovaries removed because of ovarian cancer. She was getting ready. She got to the hospital, and then the surgery was canceled because there weren't nurses to provide care in the operating room. And all of that meant that there was a rescheduling, which was like weeks later. So very stressful all around, but those are some of the real life examples that are absolutely taking place. And then the other bill, which is a very important bill, and Dr. Robin Lennox is the one of the major proponents, is a bill that's entitled "Healthcare is Not for Sale." This bill really gets to the heart of protecting Ontarians from unfair fees. It compels clinics to reimburse patients who have been overcharged or charged. Everything is overcharged if it's medically necessary. And this bill would provide clear path to disciplinary measures for those healthcare practitioners who've been caught with the excessive charging, and this could include the suspension of licenses. And we know that unless there is some type of real punishment, they're just going to continue to do it. So that's why this bill is important, and it also helps clearly define what is an unfair fee, which right now it is not defined. So these are just a few of the tools that are being used at Queen's Park. Obviously, when you sign a petition, we get to present it, but really it's about making sure that we can change the course of the debate to raise awareness in the public that these things are happening, and then to make sure that we do everything we can to protect our public healthcare system and, of course, to protect Ontarians. And that is really the objective of why we do the work that we're doing. And thank you very much for the opportunity. Oh, Jessica, you're muted.
Thank you. Thank you so much, MPP Wong-Tam, for just giving a summary of what people can do if they are concerned about being billed for medically necessary care. I'd like to introduce our fourth and final speaker before we move to questions. Michelle Ribadeau is the co-president of the Greater Toronto Healthcare Coalition. Michelle, thank you so much for being here. My question to you is, what can we do to stand up against privatization and improve our public healthcare system?
Well, that's great to have that question after hearing all of what we've heard already from the other speakers, because I guess what I would say is the key thing will be action by ordinary people right across the province. I'll just go through a few things to back that up, because when Doug Ford introduced Bill 60, which is the Your Health Act, in February 2023, he promised that people would never pay with their credit card, only their OHIP card. And the reason for that is because people hold very strongly to our public Medicare system. It's a very, people hold to it very dearly, and they support it. And it's very hard to convince people otherwise. And so he promised that would not be the case. And in fact, Bill 60 massively opened the door to privatizing surgeries and diagnostics. And as we heard, cataracts has been a particularly visible end of that. Today, all across Ontario, seniors are routinely charged thousands of dollars for, in private for-profit eye surgery clinics. And what we did as part of our advocacy in June, the Ontario Health Coalition, and we're part of the Ontario Health Coalition, filed a formal complaint on behalf of 50 patients who were charged user fees at these private clinics. We heard from an 80-year-old woman who was told she had to make a down payment of $1,500, followed by almost $11,000 for her surgery. We heard from a 71-year-old who had to come out of retirement to work to pay for his surgery. We heard from a widow whose eyesight was failing, who was charged almost $7,000 for her eye surgery and had to take out a loan. And so that's been going on. We filed that complaint. But now Ford wants to, and we haven't had any reply, by the way, from the Minister of Health provincially. We also wrote to the federal Minister of Health, explaining that these user fees were happening, that people were being charged for medically necessary procedures, which is illegal under the Canada Health Act. But now Ford is expanding to orthopedic surgeries, hips and knees, shoulders, and MRIs, CTs, other diagnostics. And we know this means patients are going to be charged many thousands more for these procedures. And, we know also about the privatization in primary care that people talked about all of these boutique concierge services and so on. The hardship and suffering that was caused that has been caused by this privatization is what Medicare was set up to stop. And so one of the things that we're asking everybody to do under the Canada Health Act, if it's illegal for patients to be charged for medically necessary care, we have a petition to the federal government, to the federal minister of health, and to Mark Carney and the Liberal government, that they enforce the Canada Health Act. That clearly in Ontario, the Ford government is absolutely not going to do anything to tackle this without pressure. So that's one thing people can do. We've also, aside from the complaints, we've held press conferences with these patients who have been extra billed. We've asked for meetings with, in Ontario, the minister and the premier, to no avail. It's not that the Ford government doesn't know this is happening. They're pretending it isn't and ignoring it as long as they're able to do so. And if that continues, we're going to lose public Medicare. Like, that's the simple thing about it. How quickly this has spread throughout the entire system is absolutely staggering. And so we need everybody to be involved in this. It was tens of thousands of people across the country who organized in town halls, faith communities, kitchen tables, union halls to win Medicare in the first place. We talked about Tommy Douglas at the beginning of today's town hall. And in that, everyone had a role to play. And today, everyone has a role to play. So aside from this petition to the federal government, which, you know, in the midst of the billions of dollars of cuts that the federal government is preparing, we know that it's going to be a massive battle to get any attention on this issue to enforce the Canada Health Act. We need to make visible our opposition to what's happening in Ontario. That means we're calling rallies across the province in the last week of September, early October. And here in Toronto, there's an emergency protest September 24th. From 4:30 to 6, we want to catch rush hour traffic in front of the hospitals on Hospital Row. We need to make the fight back very visible. And we're not going to get anywhere unless we mount that kind of political pressure. So everyone who can participate in those actions. If you need any more information about it, we have a bunch of leaflets. We're calling it Code Red. Healthcare is under threat. Of course, we need your stories as well. If you've been charged for medically necessary services, we do hope you'll contact the Ontario Health Coalition to share those stories, because we need to gather that information. So those, in a nutshell, those are the things that we're doing, but there's a big fight ahead of us. And I want to thank MPP Jessica Bell and MPP Kristyn Wong-Tam for organizing this panel, because the timing is of the essence.
Thank you so much, Michelle. We're looking forward to promoting and pulling people, residents who live nearby, and encouraging them to join that rally. Thank you for informing us about that. Okay, so we want to move to questions. And this is just me talking directly to the panelists here. I'm going to throw out the questions to you. I'm going to attempt to choose people that I think are the most appropriate. If you're like, look, I don't think I'm the best person to answer that question, you can just bounce it back to me and we'll give it to someone else, okay? So it's going to be free flowing. Because we've got a bunch of questions, we're not going to have all 4 of you answer every one. We're just going to have maybe 1, max 2, okay? So that's how we're going to roll it. Okay, so the first question, I'm thinking this is for Dr. Bashad. What services are clinics most likely to attach fees to or potentially overcharge patients for?
It's a great question. I think what we're seeing more often is the procedural specialties, especially when there's equipment required. It can be very easy to say, here's the standard lens or the standard piece of hardware versus, oh, here's the upscale version that you're able to purchase. So we do see it there, but I'd also caution everyone that privatization and private pay is slowly creeping into every aspect of healthcare. It is unfortunately something that I do think we need to be very much on alert for today. And I do worry that the more people get used to paying for care, the more it becomes part of our culture, and the less people will question it. So I really love the work of the Ontario Health Coalition, what Michelle is putting forward, that we have to remember that we do not normalize this. We have the Medicare Act for a reason, and that we should absolutely be abiding by the standards of the Canada Health Act and ensuring that we're not agreeing to charges. And it should always be okay to ask your healthcare provider questions.
Okay, so I'm going to move on to the next question. And this is a question I also had when I was listening to the presenters. And it's the question around why. Why did Doug Ford invest in these private for-profit clinics in the first place, given that we're starting to see that it's not actually leading to improved healthcare outcomes? MPP Robin Lennox, is that a question that you would like to answer?
Yeah, so I think there are a few layers to it. I think the first one is, sometimes I think when a ministry or a government is confronted with a really complex problem, sometimes, especially if they're not necessarily driven by evidence or if they feel very compelled by other factors like private interests, corporations, donors, they might be pulled towards what might seem like an easy solution. So if there is a private company that's saying, we can get through your backlogs, we can do this, we can do that, there are lots of people who have a vested interest in lobbying the government to try to put forward these proposals. If you're not willing to sort of sit down and really address the complexity of resourcing a public healthcare system, those sort of really compelling private offers might feel like a great way to say, okay, we've done something to address the problem. But what we know is on the long term, they don't bear out. We see sort of worsening problems, worsening inefficiency, increased cost drain, because I would agree with you. It doesn't make good economic sense. It costs us more money for less. It doesn't increase patient access. It actually reduces the equity in patient access and the efficiency of patient access. And it doesn't solve the root of the problem, which is underfunding, understaffing, and difficulties in just navigating the complexity of the healthcare presentations that we're seeing. People are living longer, and with that, we see a greater population with greater health needs, and that's going to put more demand on our system. But the way to address that is not to outsource the problem solving to private clinics. It's to sit down and do the hard work ourselves.
Thank you, Dr. Lennox. The next question I have is about home care. Home care is a form of healthcare. Many people rely on it so that they can stay at home for as long as possible and not move to a retirement home or a long-term care home. What is this? A question from the panel, one of the participants. What is the Ford government's plan for home care delivery? Is there any? If you could just raise your hand if you if this is something that you. Right. Okay. MPP Lennox.
And others feel free to weigh in as well. But essentially, there was a bill that the Ford government put forward years ago now called Bill 175, which basically opened up the door to increase privatization of home care. So this is when they sort of dissolved the local health integration networks and they formed the Ontario Health Teams. That in itself, we could talk about separately, but that itself was not a move towards privatization. But within that legislation, they moved towards more governing home care by regulation, meaning that there's more discretion for the ministers, and they didn't outline in that legislation who would be allowed to deliver this programming. And from that, we saw a move towards more privatization of home care services. Locally, we've seen that play out in a lot of ways where the private companies that have been switched over to deliver home care have really struggled in recent years. People feel like they have less choice. We also see that in home care, PSWs are paid by these private companies, typically are not paid very well. There's a high amount of turnover. There's not very good working conditions. And so overall, people's quality of care experience in home care has worsened because of the move to privatization. And again, it's costing us a lot more. And when we think about how important home care is in terms of keeping people in their homes and keeping people safe in their homes, this is not an area where we want to try to skimp so that private companies can make a profit. We really want all of that public dollars to be invested in good quality care for our older adults.
Thank you. The next question is around specialists. There's a lot of talk in the news and in conversations with people about issues with primary care providers, but there are some very real issues with there being a shortage of specialists as well. This is a question for Dr. Bouchard. And the question is straight up, where have all the specialists in primary care gone? I suspect this is a very, someone who's speaking from personal experience here. And they're particularly concerned about dermatologists and if we have if there is a perspective on what's happening in that specific field.
Yeah, I think a lot of the public funding for medical procedures and the physician fee codes have really not paced with inflation. And when you're able to charge a market value for, let's say, cosmetic procedures, the difference in income that you can make goes like this. And as much as I do like to believe that most physicians enter the profession to help people, I feel like a lot of them feel like they're still helping people in these different fields in a different way, in a way that's a lot more sustainable for them financially too. So I can see how it would be attractive. So definitely we are seeing that brain drain again to more private pay medicine, towards private care. But I do think that that's not even all of the driving factors. I did mention multifactorial. There's a lot of burnout in healthcare. We know that we have an aging population in Canada. We have a lot of people with complex healthcare needs, and that can be really hard too. So as much as I do agree, ask your healthcare provider the tough questions. Anyone who is worthwhile will not be offended. Please make sure to treat them like people too. Yelling at, the poor nurse, the poor physician who's working when you've had your, 10-hour ED wait, really doesn't help things. I completely understand. I'd probably be in a similar way and completely delirious if I had been waiting 10 hours for care. But as much as you're able to meet them like a human, I do think that that really does help a great deal in healthcare. It goes a longer way than you know. But a lot of people are burned out and are just leaving for different fields. I think folks in medicine often have multiple skill sets that can find way in different industries. And when they get tired of the shift work and the expectations and being not able to deliver care in a system that is failing patients every day, I feel like some of us honestly feel like we can't continue to be part of a system that's not working. So being able to, again, fund our public system appropriately, invest in the correct number of healthcare providers, really beefing up our primary care system is really key. Because as somebody who doesn't do primary care, when we don't have family doctors, my job becomes much more difficult and much more impossible. So I think building a strong primary care foundation would also help us maintain a lot of our consultants and specialists too.
Thank you very much for that answer. The next question I have is around unionization rates. I'm not sure who can answer this, but I'm going to read it and then we can see. And if it's absolutely okay if we don't know the answer to it, we can just say we're going to move on. But this is the question. Are private clinics ununionized? So the question is generally around what is the unionization rate in private care clinics, maybe compared to the public healthcare system. Among the panelists, is there any, if you could just raise your hand if you have an opinion on that or some evidence?
It's an interesting question, and
okay, great.
Would be good to get the answer to, but I don't know the answer to that. But I suspect most of the private clinics are.
Yeah, Jessica, I can get into that.
Okay, MPP Wong-Tam.
Yeah, thank you. I don't know what the union density is for private clinics, but in conversations with those who have worked in private clinics, what I understand is that the structure is largely contractual. So therefore, the person who's even working within the private clinics are oftentimes consultants to the private clinic. So you've got privatization layers of it upon each other. So I would venture out there very safely that the union density in private clinics would be very, very low, if existing at all.
Thanks for that. Okay, this is a question around, so some of these are very specific and some of these are more broad. No question is a bad question. This question is about OHIP. And the question is, why doesn't OHIP give us an individualized report that summarizes our interaction with the system at year's end? When did we access it? And then the bigger question is, what can be done to increase oversight over OHIP billing and our healthcare system? Dr. Bashard, is that a question you'd like to tackle? It's a good one.
It is a good one. Maybe pass on to someone else. I'm curious what they
say. Sure. No, that's great. Dr. Lennox?
Yeah, I think probably the barrier for the individual report would be that it would take a huge amount of resources to generate an individual report. OHIP is such a huge system that even, sometimes when we're doing research and we're trying to look at the administrative databases and all the codes, I can say that it takes a huge amount of time to sift through all of the OHIP charges and interactions with the health system that we're seeing. So I think there's probably a human resources barrier there. And in terms of the data generation and then getting those reports out to individual people. That being said, I mean, I would personally love to see my OHIP report card and understand, where I sit in sort of the healthcare utilization. I also would never want someone to feel deterred from accessing healthcare if they required a higher frequency of services, and saw that and felt, am I a burden to the system? Because we recognize that at different stages of our life and with different health conditions, we may access the system differently. We never want someone to be deterred or to feel that it's a personal responsibility for them to save money in the system. So that would be my one question there. And sorry, I forgot the second part of the question.
The second question is what can be done to increase oversight over OHIP billing in particular?
So I do know that this is looked at periodically by the Auditor General for different areas of practice, and they will try to identify outliers in OHIP billing. So we do see these reports come out often through the media. We'll see about outlier OHIP billings, particularly when the question is, are physicians billing the system inappropriately? So there is some degree of monitoring, and I have seen it pop up in Auditor General reports, but I can't say I'm sure of the frequency with which they do those audits, and whether or not they're issue specific. That's something that we could look into.
Next question is about what happens. Let's say you're a patient and you are your doctor refers you to a for-profit imaging clinic instead of a non-profit OHIP delivered OHIP funded clinic. What should you do in a situation like that? Is there anything that you can do? MPP Lennox, is that a question you'd like to take on?
Sure. And this is, again, a tricky one because I saw the question and I so applaud the desire to get in the fight and do anything that you can to not participate in privatization. That being said, the system has not been built well to support you in that fight. And I wouldn't want you to feel like you have to defer your own care in order to avoid some of these, publicly funded but privately delivered services like imaging or blood work, for example, when there are very few community-based options. You could always ask your healthcare provider, is this a test that can be done in the public system? So for example, MRIs or CT scans might be one example. If they refer you to one of these private diagnostic clinics, you could ask, is it possible to have that done at my regional center instead, which is publicly funded and delivered? That would be one option, just to inquire about the possibility of that. Similarly, for things like, hernia surgery, sometimes people will suggest a specific privately funded hospital that specializes in hernia surgeries. But you can get hernia surgeries in all types of public hospitals. And so you could decline that and prefer to go to a public hospital. But I think the bigger thing is rather than, us just focusing on our individual care, I think it's about raising your voice, talking to the people in your network, your family, your friends, your coworkers, the people who trust you, and talk to them about what you now understand to be happening with privatization and encourage them to raise their voices, to sign petitions, to get involved in movements. Really, I think it's about making this a large movement of all of us rather than, just what we can do on the individual level of our own healthcare. And Melanie, I think, has an ad. Yeah.
Yeah, just very quickly, again, beautiful question. I agree entirely with Dr. Lennox. I did want to reiterate that not everything outside of the hospital is necessarily bad. Nonprofit institutions usually don't have the same issues that we see when that for-profit motive is introduced. And we also can keep in mind too that a number of physicians who are working in their standalone clinics, it's technically a for-profit institution. That physician is hoping to make a profit, but we do find that there does tend to be less of a corporate profit motive as opposed to a chain institution that's owned by shareholders, and there's a corporate board of directors who are making very strategic decisions to try and maximize profit. Obviously, an individual physician is going to do that too, but they have more of that direct fiduciary responsibility to the patient to keep the patient best interest in heart. We have a college and oversight to do that. I think it's a little bit easier to do that in a group that's run by physicians as opposed to a group that has this corporate oversight there. So I did want to make that little distinction. Maybe the place where you went was nonprofit or didn't have some of those same issues.
Thank you for raising that. We have a few other questions that I don't know if we'll get time to, that had some questions around what is our position on nonprofit healthcare clinics. So in some ways you answered that by providing the different distinctions. This is another patient example. This question I believe would be good for Michelle Rebaudot, and it is a patient's experience. So I'll just read it out. It's about a patient who went to an optometry service. They said they went for a simple checkup and they were sent for various tests. It was never explained to me why they were required or how much it would cost me. At the end, they charged me almost $300 for tests OHIP wouldn't cover. What should I do in this situation?
So this happens a lot, and it's happening to people, for example, who are preparing for cataract surgery and they're told they need a special measurement and they have to pay hundreds of dollars for this special measurement, which is not medically necessary. The problem is when you get charged afterwards and you haven't had any of this explained, people are ending up paying because they feel on the back foot about it. But document it. And get in touch with the Ontario Health Coalition, info@ontariohc.ca, with that information documented, because the thing is, we are fighting right now to get reimbursements, to force medical providers to say what it is that is being prescribed, and if there's a cost, why, if it's medically necessary. The problem with optometrists, I mean, it's a whole other thing. There's a long history here in Ontario of what's happened. But if it's related to medically necessary surgery like cataracts, you have to document this. The thing is, now we're having to pay all the time to go and get our eyes tested. And that's something maybe either Melanie or Robin could address about the specific structure around that. But if it's part of, a surgery or a treatment that you need, that's medically necessary, you should not be paying for any of that. Same with drops. A lot of people are being charged for eye drops. This is part of it. If you didn't do the eye drops, your surgery would not be successful. And so you should not be being charged for those things, but it is absolutely everywhere now. People are being charged, and that's what we're trying to push back on as a movement, to say this has to stop. And it's just, the titanium screws for hips and all of this stuff, it's going to be coming like a flood, and people won't know what hit them.
Thank you for those examples. I have a question about the federal pharmacare plan. This is a question for Dr. Lennox. The question is this: under the federal pharmacare plan, will generic and brand name versions of all medications be covered for people on Ontario Works, ODSP, and anyone else who needs it?
Thank you for the question. So the federal pharmacare plan, which, by the way, the Ontario government has not yet signed on to, so it's not yet available in Ontario. That federal pharmacare proposal only applies to two types of medications, so to contraception or birth control, and to diabetes medication. So it doesn't apply to all types of medication. It would, so those two types of medications typically are already covered for folks who are on Ontario Works or ODSP in Ontario. But it wouldn't apply to any medications beyond those two classes. And again, it's not currently available in Ontario widely because we haven't signed on to that federal pharmacare plan yet.
Okay. All right, so here we go. All right. Okay, so this is a question. I think this would be a good question for Dr. Bouchard. And it's, I'll just read it out. Is there a reason that health-related devices such as glasses and hearing aids are not covered as part of the regular healthcare system where you can bill OHIP?
I think we haven't raised enough of a stink about it yet, actually. I do think that this is an oversight. I think it shows the fact that Medicare was rolling out in the 1950s and 1960s in Canada when maybe these devices and these technologies weren't as much of a consideration, didn't have as much widespread use and availability. But we see huge gaps in our universal healthcare system, universal using some air quotes, because we could say the same thing about devices, but also what about like outpatient mental health care to see a clinical psychologist? What about eye tests? What about outpatient pharmaceutical medications like Dr. Lennox was just speaking about? And it really makes you wonder that if somebody was dropped into Canada day one and they found out that if I'm admitted to hospital, my medications are covered, but if I'm discharged and they prescribe me medications, I all of a sudden need to pay for them, you realize how nonsensical it is and how many gaps our quote unquote universal healthcare system has. So I don't think there's a great reason. We do have a group at Health Canada called CADIT, Canadian Association of Drugs and Technology in Health, but hopefully getting the acronym right. I had a 6 a.m. shift this morning, so forgive me if I'm a word or two off. They essentially do an evidence-based assessment of new drugs and devices coming to the market and help make recommendations for what should be on public formularies. But that being said, if there isn't a precedent to cover a certain class of devices, even if it is evidence-based and helpful, it still may not be covered. So I do think that as much as we want to defend what we currently have, we should always be looking 2 steps ahead and looking at what else we can bring into this universal healthcare system. How can we cut costs down for patients?
Thank you very much. I believe there is one more question that we can do before we'll move to wrapping up. And this is a question about Dr. Jane Philpott. Dr. Jane Philpott was a former Minister of Health and was recently signed up last year by the Ontario government to advise them on healthcare. And this question, this individual is curious about what work is Dr. Philpott doing and how could it change Ontario's healthcare system. Is there anyone, one of the panelists who would like to answer that? Okay, I see Dr. Lennox.
Yeah, so Dr. Philpott is primarily charged with the primary care action team for Ontario. And so she's mainly focused on trying to enhance access to primary care, so a family physician or nurse practitioner across the province. Recently, Dr. Philpott and her team did inform a piece of legislation called the Primary Care Act that was passed in the last session, which we as an NDP caucus were happy to support because it basically envisioned the expansion of team-based primary care across the province so that every single person, the vision is, should have access to team-based primary care, and that's a vision that we agree with. There have been some recent funding announcements for the expansion of team-based primary care through family health teams. But certainly we still see a huge gap in terms of access to primary care, particularly in rural and remote regions, and for populations that are generally underserved or have barriers to access in primary care. And that, again, that work only applies to folks who are OHIP insured. So it's not doing anything to address access barriers for people who do not have an OHIP card or are ineligible. But that work is underway and we're keen to see sort of what else comes from it.
Thank you so much. I want to thank all the panelists for sharing your expertise and your personal experience tonight as organizers, as medical practitioners, as MPPs, as people who use the healthcare system. Thank you so much. I learned a lot, and I'm sure many of the people who were watching and listening learned a lot as well. I want to end it with a quote. This comes from Tommy Douglas, who was the former Premier of Saskatchewan and who brought in public healthcare to Canada. And I like this quote because it's very personal and it just says a lot. And he said, "I felt that no boy should have to depend either for his leg or his life upon the ability of his parents to raise enough money to bring a first-class surgeon to his bedside." And I think it was out of this experience, not at the moment consciously, but throughout the years, that I came to believe that health services ought not to have a price tag on them, and that people should be able to get whatever health services they require, irrespective of their individual capacity to pay. Anyone who has had to care for a loved one or who has been sick understands the value of this principle. It is a principle we uphold as Canadians, and it's a principle that we very clearly need to defend right now. I look forward to working with the presenters and to many of you who are listening and watching, to organising and working with you to stand up for our public healthcare system and using every tool that is available to us to do that. From writing letters, to having meetings, to introducing legislation and amendments, to protests, to educating people, to standing up for ourselves if we are finding that we are being billed for things that we should not be billed for, to doing FOI requests, to working with the Auditor General and more. We've had some very practical examples of things that we can do in the next month or so to stand up for public health care. We have a rally that's being organised by the Ontario Healthcare Coalition. We know that the Ontario Healthcare Care Coalition and our offices can provide you with practical advice if you're wanting to challenge a bill. Please, I encourage you to volunteer and donate and follow the organisations that have spoken here tonight. And you're always welcome to contact our offices if you need help one-on-one, or if you want to work with us to protect our public healthcare system. I know we didn't get to answer all the questions tonight, but we did get through a chunk. We will follow up with notes and contact information, as well as some of the, outlining some of the key events that are coming. I want to thank you so much for coming. It shows that you care about our public healthcare system, that you decided to be with us tonight for this hour and 10 minutes. We really appreciate it, and we look forward to continuing to work with you. Have a good night.